It's a pleasure to me to be here to present this case from Hospital de Base in Brasilia. I am a trauma surgeon. My name is Wellington Santos, and I'm representing our service, Hospital de Base, and our society is BITE, okay? And I'm going to talk to you about the trauma of the portal system. I think this is a very curious case, and very is necessary for the surgeon to have some abilities and have some strategy to conduct this case, okay? Yes, I present you our research that we have into this case. We have a blood bank, okay, laboratory, machine of blood gas analysis and X-ray. We have a CT angiography, but this CT is not exclusive for trauma, okay? We have, because we have COVID in nowadays, and we have to completely this room with another patient. But we have the CT in our hospital. We have the operation room that can perform in 24 hours, and this is our emergency room. We don't have a massive protocol transfusion, but if necessary, blood it's very fast to take to us. And at this time, our ultrasound was broken because this weekend our ultrasound is not functioning. He was broken, okay? And this is our researches for this case now, okay? We have a patient of 15 years old. He was admitted in July 18th to the red trauma room coming from a public road, transported by firefighters. He arrived with a history of physical aggression in his school, and he has a traumatic brain injury. He has some injury that can show that he has aggression in his head, and he was associated with abuse of alcohol, okay? At the emergency room, he has pervious airways. He wasn't with a cervical collar, and he had ethylene breath, okay? I'm just to take it out here, okay? Just a few have something happen here, just to just a few something happen here. Okay. He has a decreased blood flow lung responsibility with a vascular murmur bilateral decreasing base. Breath frequency was 16, and saturation of oxygen is 98% with oxygen with mask 15 liters per minute. No active bleeding was observed, and stable pelvis, and he has a capillary refill times more than 3 seconds, and he has heart rhythm with 68 beats per minute, and blood pressure was 110 to 16 milligram of millimeter of mercury, and the fast is not unavailable, okay? He has Glasgow with 10th, miotic pupils and fault reagent, and movement all member, and he was agitated at the moment. And he has scoriation in his face, okay? And I ask to you, hypothesis of diagnosis, this is just the history that we have for him. We have a poor history. Is a patient who was in alcoholic, okay, and he had aggression, physical aggression. And what you are going to deposit diagnosis, and I ask you, the patients, can you take to him to next case was indicated now.
Dr. Antret?
Yeah, so it sounds like just an altercation, physical altercation. So he was struck. and without, he wasn't stabbed, but just sort of blunt trauma in a barroom brawl with somebody else, if I understand correctly. So, and you mentioned that he has signs of closed head injury. He's got myotic pupils, but no localizing signs. So really need to get a general sense. So I would look for do a full set of labs to look for any signs of intoxication to explain his combativeness, and then chest X-ray, pelvis X-ray, and urinalysis. And then at this point, he's hemodynamically stable. So I would still type in cross-match for 10 units of red cells, fresh frozen plasma, 10 units of platelets, because you don't have the massive transfusion protocol. And then I would take him to CT, but accompany him there in case he deteriorates.
Okay. We have made X-ray test, and there is no one finds in the X-ray chest.
Okay, thank you, Dr. Antrach. Dr. Kasim?
I agree with Dr. Untract's summation so far. I think the difficulty in cases like this is when somebody comes in after altercation with TBI, you don't know where to start and how far you should go, especially in an austere situation like this particular institution has. Some of the moving parts that's needed to care for a patient like this is missing at this moment. So you need to be aware of that. So my teacher taught me a long time ago, if you can distinguish this patient needs emergency care by experts, and this patient can be kept in a local hospital, you are 50% there. So the question that I would be asking would be, how much can I offer this man, this patient, in the care of his trauma, and what would be my restriction, what would be my capability, and all those needs to be answered within to myself, and then to see, should I keep this patient in my trauma bay, or should I seek help from tertiary care, send it to Boston to Dr. Hoyman, who is an expert in treating patients like this. So that's something that we don't teach residents nowadays, because most of the time we just go ahead and nilly-willy do everything, and then after that find out perhaps this patient would have served better elsewhere, elsewhere. So keep that in mind. So what would I do in a patient like this? I think obviously, I'm worried about what type of injury he could have sustained. Should he undergo a pan CT or so-called man CT? Or if first of all, is it working? Is the CT working? Is there somebody to interpret the CT scan? And all those needs to take into consideration. As we speak, he is not in traumatic shock, but then he's young. He probably is compensated. He does have, TBI, and that may cause problem down the road, with either minutes or hours, who knows. So those things need to be taken into consideration as well. So yes, CT scan would be an adjuvant that will be very valuable in evaluating this patient. I wish we had the fast available, then we could have known that whether he has any intra-abdominal or intrathoracic bleed, that could have helped us. Thank you. Sorry, took too long to summation.
No problem, Dr. Kasim. Thank you so much. Dr. Colette?
Yes, I think this is a very interesting patient because he is alcohol. and he's agitated, and he has some Glasgow Coma score 10. Some people maybe a TC, a Brian injury. In this moment, this patient is maybe agitated. You can, maybe something important when you can see refill times, capillary refill time is bigger than 3 seconds. And maybe sometimes maybe a shock, compensates shock. So I think in this moment, these patients need to go to weigh a resuscitation, start to see. And this patient, I need an image to know what's happened because he has only scoration in the face. He was aggressive, aggression. He has is maybe injuries in any part of his body. And sometimes it's not there are signs to see where is. If you don't have signs, you have to find what's happened with the patients. Maybe nothing happened, but maybe several big injuries in the abdomen or in the chest sometimes, and in the brain. So these patients, of course, need after the resuscitation, needs a brain CT. And I think these patients need a body CT because he needs to know if there is some injuries in other part of the body. There is no signs, external signs, but he was a victim of the aggression. This is very important to know where is. If you don't have, no problem, can observe. If you don't have the image, it's become difficult because you have to observe the patient. And the patient with a Glasgow Coma score 10 is very difficult to evaluate the abdomen signs, and the other signs may be difficult to know, and you have a very big problem with this patient. So I think these patients need to go to have a CT to try to find what's happened.
Thank you, Dr. Colette. Dr. Hoffman is available now, or?
Yes, I'm sorry.
Okay.
I got paged for something that was quick. I don't have too much to ask. To add, this patient, I will do a chest and pelvic X-ray as we do routinely in the trauma bay, and after that, this patient will go for a CT scan. My suspicion is that he probably have narcotics on board. That's the reason that the heart rate and blood pressure might be low, both of them, and he has myopic pupils, and he was drinking, so I wouldn't be, at least in Boston, I wouldn't be surprised if they have narcotics on board. But this patient is stable enough to go for a CT, and I will do a pan CT because you don't have a reliable physical exam on this patient. Thank you.
Thank you, Dr. Hoffman. Dr. Chiodetis?
Hi, good morning, everyone.
Good morning, doctor.
So this patient, I think, is really, really sick, independently of how stable the vital signs might seem. So I will ask this patient to be intubated, the airway secure, get a chest X-ray and a pelvic X-ray, and also an ABG if it's available. Get some blood if we have it, and if not, well, we should resuscitate him with some crystalloids, and also after that, and I make sure that everything is all the things that may hurt him right now. Then I will send him to CT if you have available. If you do not, this patient needs another level of care. So let's see what happened next.
Thank you, Dr. Chiodetis. Dr. Santos, we return to you.
Okay. I think this patient, it's a really trap. Okay, when you have a patient like this that he has abuse of alcohol, we need to double our care to him. Okay, and like Dr. Colette said, we get 2 large caliber venoxas and take to him 500 milliliters of solution of a ring lactate. Okay, we collect both a gas analysis at that time showed normal. Okay, and we indicate a CT of all the body, CT of cranial and cervical without contrast, and CT of chest abdomen basin with contrast. But we were in the COVID, we are a pandemic thing, and there was a COVID patient was finished at CT and delay 25 minutes this patient come to CT, okay? And patient stay at our emergency room for 25 minutes, and he goes to the CT, and we have here after when he come back, he come back unstable, blood pressure decrease 85 or 60 millimeters for mercury, and heart blood beats, this was 105 beats per minute. We give to him another a liter of ringer lactate solution, and now we take to him 1 gram of tunexine X. This is the
Doctor, I'm seeing the same slide. Is everyone else seeing the same slide? Yes.
Yes.
Okay. Okay.
This is my slide. This is in the emergency room. Can you see this? There is a red. I am put here gas blood analysis. Do you see this?
No, sir, we're not seeing your slides.
Okay, I'm going to return. I'm going to come back here.
There you are.
Here. I'm going to put another time. Do you see?
Do you see now we're seeing the conduction to this page.
Okay, conduction page. We take to him 2 large caliber venous access. We give 500 milliliters of lactate solution. We collect blood gas analysis that show at that moment normal, and we gave a CT of cranial, a cervical without contrast, and a CT of chest abdomen base with contrast. But we have a patient that was in our CT and was finished the CT, okay, and this delayed at 25 minutes to take our patient to the CT. When this patient come back from CT, he come back stable. His blood pressure was 85 to 16, and he has his frequency was 105. Okay, we give another solution, another liter of solution of lactate, and at this time we gave to him 1 gram of tonacid acid. And this is the blood gas analysis that show that patient has a basic cis was -10 and lactate was 4.46. That show that this patient he has a perfusion that's not very good, and he has the hemoglobin 80.7. And this is the CT. Did you see my screen? Do you see my screen?
Yes, we can see your screen.
Okay, and this is the CT. The chest and the cranium was normal, and the cervical was normal. And this is the abdomen CT that showed that he has free liquid in the perihepatic. You have a liquid in the Morrison space, and we have here a great hematoma, big hematoma near to the pancreas, the head pancreas, and we have this hematoma with relationships with a portal vein. Portal vein, we have here the relationship hematoma with the portal vein, with the superior mesenteric vein, and there was signs of active bleeding from here. We had at the moment blood in the Morrison space, blood perisplenic. You can see here blood peristaltic, and we have blood in the hypoglossal, and this is the great hematoma. Okay. Do anybody need to make any comments about our CT? And this is, and here he has a blood in the hypoglossal near. This is our patient. This is when he come back from our CT. Okay. I'm asking to you what we're going to do now with these patients.
Okay, go ahead, Dr. Horstman.
Okay, well, this patient has to go to the ward. That's the short answer. There were many indications that this patient was not doing well at this time. By now, he is more hypotensive and tachycardic. I don't know why his heart rate was only 65 initially. I don't know if he was on beta blockers, 50 years old maybe. But the elevated lactate and the acidosis, which is partially compensated respiratory-wise, indicate that this patient has probably significant blood loss. Now looking at this CT scan is really bad. This appears to be an injury at the head of the pancreas, probably at the level of the neck. Those injuries, they are very difficult to control, but this patient needs to go immediately to the operating room. It's a nightmare trying to control the portal vein at that level, particularly if the patient is an alcoholic and might have signs of cirrhosis, although I don't see any signs of cirrhosis on the CT scan. So this patient go to the ward and for an exploratory laparotomy, and probably, I'm guessing based on this, a distal pancreatic resection. I don't know how is the duodenum, where the extravasation is coming from, but it's very difficult to get vascular control in this area. Thank you.
Thank you, Dr. Horstman. Dr. Kasim?
Well, obviously, this scenario has changed for this patient by the time he returns back to the trauma bay after a 25 minutes delay in getting a CT scan. And he's hypotensive and he's tachycardic. And if you add all the other labs that you have seen, they are superfluous, not really needed. And you look at the CT scan, he's got blood around the liver, he's got blood in the lesser sac, he's got blood in the portal area, head of the pancreas, and you add all those together, but there's obviously extravasation noted as well. So that makes the urgency paramount. He needs to go to the OR, and what you do in the OR, it becomes even more critical. This injury is severe injury, and this injury will distinguish men from the boys, and you need to be an expert in dealing with this. This is not ordinary, hepatic laceration or liver laceration or some splenic laceration. This is the real tiger country. Tiger is there, and it's going to bite back at you if you don't treat it well. So in the operating room, I think you have to have a game plan, exactly how you're going to approach it. And you must know some basic methods, how you're going to go about treating this, because trust me, this is not an ordinary injury. This is a very critical injury for this patient, and his life depends on what you do in the operating room. Thank you. I would be very interested in knowing how we're going to go about dealing with it, because I'm sure that each one of us probably have a different method of dealing with it. Thank you so much.
Thank you, Dr. Kasim. Dr. Colette?
Yes. I think it's very important that these patients you have this image to decide what to do. If the patients you have the ultrasound, the fast exam in the emergency room, sometimes you can put the patients in the OR in initial assessment without the CT. So the CT is very important. I think the delay was important too, because the delay may be the aggravated patient. So I think that when you have trauma centers or emergencies that you need to have patients, the CT must be stopped and wait the patients on the trauma bay or the trauma in the situation. So this patient, you have an injury on the head of the pancreas, you have an hematoma, you have active blending. So sometimes you can ask if the patient's need, maybe in this situation, you may be thinking about Reboa for this patient to control the hemorrhage in the initial surgery step. Or you have sometimes when you start the laparotomy, you can see that the injury is in the middle of the pancreas. Sometimes you need to make a cross-clamping aorta, can be done through the hiatus or through Mattox maneuver. So these patients, you need to, before the approach, the injury, you need to make a arterial control if possible. So I think this patient is maybe a case maybe useful to use Reboa. Sometimes these patients you need to be sure that when you start the surgery, you can go to aorta cross-clamping control to the blood to hemorrhage in this area.
This was a great case for to Reboa, but we don't have Reboa on our service, okay? But it's very interesting, your comments, Dr. Collet.
Thank you, Dr. Collet. Dr. Chiodetis?
So I think this patient needs the OR immediately, and you must be prepared to do a resuscitative thoracotomy, because this patient is gonna completely crash once you get him intubated in the OR. So I will be prepared and get everybody on board to do a resuscitative or reanimation thoracotomy, cross clamp the aorta, and then do a very, very fast the abdominal exploration, trying to evacuate all the blood and try to get some control to get to this injury. I think we need to get blood, enough blood on board, PRBCs and FFP, and the use of tranexamic acid. I think it was really good for this patient, and also get a anesthesiologist to know all the bad things that is happening to this patient.
Thank you, Dr. Chiodetis. Dr. Antrach?
Yeah, so I agree with Dr. Collet that had the ultrasound been working, this patient probably would have gone straight to the operating room without the head CT scan. The fact that he was combative, had no focal findings, and he had bilateral myotic pupils, I think that was enough to delay the head CT if you already had a positive FAST. Also, given that the patient had to go to CT, I think it's better in this case because there were signs that what happened was going to happen. So it's probably better that these patients go monitored with a senior or junior resident accompanying the patient so that it's not a surprise when he comes back hypotensive, and potentially transfusions could have been started in the CT scan, and the CT scan stopped as soon as the blood in the abdomen were discovered, and would have saved some time. In the operating room, I would start with a conventional midline laparotomy, be prepared to get control of the aorta at the hiatus with just by tamponade if necessary, and then look for other signs of bleeding other than the head of the pancreas. And then if all that was excluded, then need to expose that area. And over there, assuming I had control of the aorta or potential control, then I would do a right right medial visceral rotation with a Coker maneuver and explore the area of the portal vein and the head of the pancreas through that approach.
Thank you, Dr. Antrach. So Dr. Santos, we go back to you.
Can I, Valeria, could I make a comment too?
Of course, of course.
Yeah. So, like I said, this type of case distinguish men from the boys. And as soon as Dr. Collet comes along and he gives you the gem of the case, exactly how he would manage. And, I love listening to this man. He's such a master surgeon. Exactly what he should do. You do a midline incision. Don't do a thoracotomy because you're adding another layer to this case. You don't want that. You do a laparotomy, get control of the abdominal aorta, like Dr. Collet says. Then you go and play around where you want to play. Either you do a catal or whether you do a matter, or you do a both. And in my hands, I think I would do a both after I get control of the abdominal aorta. Get a cross clamp around it in the hiatus, like that own truck says. And then you do the 2 maneuvers named after very famous surgeons. And then you're looking at the scene of the crime, so to speak. You're looking at the area of the head of the pancreas, the portal vein, confluence of the splenic vein and the supramesenteric vein forming the portal vein. And then you'll be looking at the area there very clearly, and you will be able to see where he's bleeding from after you have evacuated the hematoma. And then you have to make a decision what you're going to do next. I think Dr. Collet gave us the gem of this case at this moment. We'll see where we go from here. Thank you, Valeria.
Thank you, Dr. Kasim.
I'm sorry, Valeria, can I make one quick correction to Dr. Kasim? This also separate the women from the girls. I think that this is in the, I don't know if we really need to do a catel or a Mattox maneuver. This is kind of in the center of the abdomen. Probably the pancreas is transected. The bleeding is coming from the duodenal arteries, probably. If you need to get proximal control, yes, maybe a thoracotomy, or just probably going under the diaphragm and clamping the aorta there. But this is going to be also a lot of venous bleeding from the portal system. So it's not going to help too much anything that is not done locally. This is the problem with this type of injuries. Normally, any vascular injury, we get proximal and distal control. Here, there is no space where to get the proximal and distal control. Thank you.
Thank you, Dr. Oshman. Dr. Santos, we go back to you.
Okay. We proceed laparotomy exploratory, and in that moment, just a few, we make the proximal control of the bleeding. We make a supracerebral aorta control, and we make the clamp in aorta in the esophageal hiatus, and the patient stay with this clamp with 50 minutes. After this, we identify the massive and peritoneum, and we have a hematoma in the zone 1, and we make a catel brach with a Koch maneuver that we cannot find a bleeding from the inferior vena cava. And we find a lesion, the confluence of the superior mesenteric vein with the portal vein. We have a pancreatic head injury with associated anterior pancreato-duodenal arterial injury, all a mixture. We made the ligature branch of the portal vein and the pancreato-duodenal artery. We made a primary raphia in the pancreatic head injury, plus we made a drainage with a tubular tube. After I released the aortic clamp, no bleeding was observed. Okay, here we have an image that we can show where we had an injury. Here is the portal vein upper we have the splenic vein, and we have the superior mesenteric vein, and we have here the suture, and we make a repair with a Prolene 40 with a continuous suture, okay? And we have here where we make the clamp. I think this clamp, it was very important when we procedure this maneuver. It was very easy to identify, and he's the head cavity of peritoneum of the people that has a big clot and has a active bleeding. And you can see here the image that the film that can make. You have here the head of the pancreas that there is just a injury, okay? And we have here the suture now that we make in the portal vein, in the superior mesenteric vein to the confluence to the portal vein, okay? And this is and the patient to stay with the clamping aorta for 15 minutes when you put a Satinsky in this place that can make possible to make the suture, okay? And this is the case. I will tell you about the evolution after you can make your comments. The patient involved to unit care bed, and he gets stabilization and improvement laboratory tests. And daily he has a depth abdominal draining with 14 to 7 milliliters per day. And this is the dosage of amylase and lipase that we have here. That serum amylase, it was decreased, okay, but the drain amylase was too high next week, and they show that the patient has a pancreatic fistula, okay, and we are programming now. Look, this is the CT of control make in next weeks. This patient, he's still in our hospital, and show here that there is no leak here. He has a little collection here for the head of the pancreas. This is a adrenal. This is the drainage that he has from the pancreas, and he has just a little collection that it is going good now, okay? And after this, the patients evaluate with a pneumonia that he's treating, and we are programming to him endoscopic retrograde cholangiography to make in next week, okay? Because we have the problem, because our service, we don't have the prosthesis to put in his to make the drainage, and we just use a prophylactic inoculation to this patient with enoxaparin. We made the suture at the portal vein, but we don't use the anticoagulation to the patient like a treatment. We just make a prophylactic anticoagulation with enoxaparin, okay? And this is the case if you want to make your comments now.
Thank you, Dr. Santos. There is a question in the chat that says if there was a cholangiography done.
No, we will make this next week, okay? Okay, but patient, he's going well, but the amylase for the adrenal is getting high. Today it was next weekend it was 21,000, okay, and we are going to program the cholangiography to next week.
Okay, thank you so much. Okay, Dr. Kasim. Your comments, please.
Fantastic case. Really good case. So the surgeon, you must have trained under Dr. Collet. You read his mind. Exactly what he said he would do, you did it as well. Fabulous case. And once you get control of the abdominal aorta, and then if you want to see the scene, panoramic view, I'm afraid, as opposed to Dr. Hoyman, I would say, I think you are mandated to do a Cattell maneuver or Medax maneuver so that you are at the leisure of seeing the whole thing. You get to see the whole scene of injury. You don't have to work through some keyhole to see where he's bleeding from. And that's exactly what you did. And then you got lucky as well. It was a linear tear and you were able to repair it beautifully and without any subsequent narrowing of the vessel or anything like that. And you didn't have to put a shunt in, you didn't have to deploy anything else. And very nicely done case. Love it. I love the case.
Thank you.
Fabulous. Thank you so much for educating us today.
Thank you, Dr. Kasim. Dr. Chiodetis, your comment, please.
Well, Dr. Santos, congratulations on this case. It was really, really good. And I want to ask you, how much blood did you give this patient during the OR?
Yes, when we opened the patient, there was 1.5 liters, and we make four packs of blood and another packs of plasma. Okay, just this. And to help make the patient, we make it to a gluconate of calcium to him, and it was this. But patients stay intubated in the unit care for 10 to 12 days. It's necessary to make a tracheostomy, but patient he is in rehabilitation now.
Thank you.
Thank you, Dr. Santos.
He's going well.
Good. Thank you. Congratulations.
Thank you, Dr. Chiodetis. Dr. Antrecht?
Yes, so I agree. Nicely done, and I can see the point that the reason for the visceral rotation was to get a full exploration of the area, and then it turned out that the IVC was fine. So if you hadn't done the visceral rotation and it just went straight to the head of the pancreas, that would have sufficed, as Dr. Hoyman, that was his point, and I agree with that also. If you know or can use judgment as to what's injured and what's not. So I take it that you got exposure through the gastrocolic omentum, is that right? To expose the portal injury, Dr. Santos.
I didn't heard. Can you repeat to me?
Yes,
please?
the exposure to actually expose the portal venous injury, you divided the gastrocolic omentum and entered the lesser sac and approached it that way directly. Is that right? Without needing, in fact, the Coker maneuver or the Cattell maneuver, that you could have and ultimately exposed the injury through the gastrocolic omentum?
Yes. When you make the Cattell plus the Koch,
Yes,
signifies a bleed in the cava vein, and you enter into head cavity from the pupils, and we find that that patient has a active bleeding come from there, and he has a injury near from the stomach, and can show that that the patient has a bleeding at there. We try to make a clamping in the how can I say? I forget I forget now. Just a few seconds. We need to make the maneuver of just a few seconds. I forget the sentence. Excuse me. I try to make the.
Maybe Dr. Colette can help you translate.
Okay. Manobra de. That just a few. I forget now. Okay. I will answer the few minutes. Okay.
I think Dr. Untrak, he did do a Cattell maneuver.
No, I know he did. He did the Cattell and then the Coca maneuver, but and I think
Yes.
Dr. Hoyman's point was it wasn't in this case because the injury was exclusively limited to the area, the head of the pancreas. That had he not done it, that would have been okay too. That he did the maneuver, everything was okay, and then he went went directly to the head of the pancreas. And my question was, I think to expose that area, I think that looks like it was through the gastrocolic omentum, if I
Yes.
interpreted the picture. Right, yes, exactly, right. So that's the point, but I think that, the points are all well taken, that you want to get a good exploration and depending on the situation and, and then, so in this case, it sounds like the patient is more than a month post-op and he still has the drainage, but is doing very well, probably eating. And if I didn't have access to ERCP, or even if I did, and there was going to be a delay, I might be tempted to do a fistulogram through the tube, and then you can see exactly how it's draining. But even that is probably, it might be even more meddlesome than just leaving it alone. It's probably a side fistula that's going to close, and eventually you can pull the drain out, advance the drain out slowly, and he may need a stent through the through the ERCP to help that along, but but by and by, I think it was a great case, excellently managed. The only thing I would do differently is the patients where there are signs that they may become unstable, the junior resident at least should go with them, monitor along the way, be prepared to intercede with the resuscitation and the CT the scanner, but it's a really very instructive case.
Okay. If I can ask you, when you enter at this region, this incision was made by the trauma, okay, and we don't need to make no war. We just to identify the vessels and make the suture. Okay, it was this.
Yeah, and it was quite a gut punch by the assailant.
Yeah, must have been.
Okay.
Thank you, Dr. Antrach. Dr. Hartman?
Yes. It has to believe that this happened because somebody beat him up. I would have thought that this was a car accident or a motorcycle accident, because it's a significant blunt force to transect the pancreas against the spine. But yeah, I guess it can happen. In this case, first of all, the mortality of these cases is extremely high. So yes, congratulations to you for doing this. These patients usually exsanguinate in the table. It's very difficult to get proximal and distal control to make the suture of the portal vein. Yeah. So this shows that you really are a very competent surgeon. In this case, a few comments. In this case, the transection of the pancreas was done by the trauma, but there are cases where the bleeding occurs, usually more penetrating trauma, and the pancreas is still in place. And a trick that I learned many years ago from an old surgeon, and served me very well since then, is that in order to get control of the portal vein, many times you need to divide the pancreas. And this is very counterintuitive. People are always reluctant to do anything like that, but there is no other way sometimes to get the control of the portal vein than dividing the pancreas, and after that you need to do essentially resect the distal end. I don't know if the distal end of the pancreas was resected, but usually what is recommended in these transections of the pancreas is to resect the distal end and leave the head in place. Patients usually do not become diabetic and oversaw the head of the pancreas if there is any And I know that the books say to isolate the Wilson duct and ligate it separately. A few years ago, I went and I tried to find a reference, compare one way or another, and who has the time in a case like this to look for the Wilson duct. I didn't find anything. I think that's kind of like a myth that is being repeated, but there is no scientific basis for that. The majority of the surgeons just suture the end of the pancreas and they move on. Another important thing for this type of patients is to start DVT prophylaxis very early, because significant number of patients will have a thrombosis of the portal vein, which can be very problematic. And you did that, you started the prophylaxis early. So I can only congratulate you for this. This is a great case, managed very, very well. Hope that you present again soon. Thank you.
Okay. Just a few. I just to remember the two other surgeons that can participate in the surgery. It was Dr. Alberto Toledo, he was from Equatorian, and Dr. Fernando Gali, both of them are trauma surgeon, and then can participate in this brilliant surgery. Thanks for them.
Thank you, Dr. Hartman. Dr. Colette, thank you for your patience.
No, no problem. I have to have congratulations for the case, but I think it's something is important. Something is more important than you suture the port. And if you don't have doubts, if there is a fistula, you put a drain. And don't make big surgeries at this moment, because sometimes it's very difficult and maybe more problems with this surgery. For the other, I see these patients have a pancreatic fistula. I think it's important before to make the CPR and maybe study the pancreas by a contrast extrude of the duct. You need to make a resonancia, MER, to see the duct, because if this the resolutions of MECR is very good for to see the duct, you can see if there is an injury of the duct, and you go to the CPR, you can use a stent to correct the ductal injury in this situation. Sometimes you can see the student prepare to the CPR to put a stent in the duct. So I think it's very important the study of the pancreas at this moment. Congratulations on the case. It's very difficult to approach in this area and to take to share the case with us. Thank you very much.
Okay.
Thank you, Dr. Colette. Okay, anyone else have a comment?
Yeah. Yes, just a follow-up question. So if I can just ask, was the pancreas itself disrupted or was it just bruised and surface injury? I'm not quite clear on that.
There was just a injury in his head. There was a big hematoma, and you cannot find another lesion in the head of the pancreas.
Okay, and so you that picture on the right-hand side where you show the portal vein, splenic vein, that was simply by retracting the pancreas anteriorly. That's basically the pancreas under your fingers, yes, and retracted. Yes. Okay.
Yes.
Yes.
When we enter in this area, we think that the pancreas there is a rupture, okay, because there's a big hematoma. But after when we can look better at the structure, we cannot note that the pancreas was just an injury in his head.
I have a question. How long did you cross clamp the aorta for?
50 minutes, okay. After, when you come here and you get the control of the portal vein, and when we identify the bleeding for the pancreatic artery, we take it out to the clamp for an hour, 50 minutes.
15 or 50?
15.
No, 15.
15. 15. Thank you. Thank you.
Okay.
Okay, Dr. Santos, thank you very much for presenting today. Thank you everyone for your comments and your time. and we look forward to seeing you next week.
Okay, thanks everybody.